A very good morning to one and all present here. I'm here to present the clinical aspect of the second case for today's CPC. So, our case was a 25-year-old female hailing from Kaithal, Haryana, with a total duration of stay in PGI of around 48 hours. She was treated in RICU under the unit of pulmonary medicine. So, patient on presentation had complaints of fever for 6 days, pain abdomen with vomiting for 3 days, shortness of breath and reduced urine output for 2 days. So, patient was apparently all right 6 days prior to presentation when she developed high-grade fever associated with chills. 3 days back, she developed generalized pain abdomen associated with vomiting. And 2 days back, patient had rapidly progressive shortness of breath associated with reduced urine output. There was no history of altered sensorium, no history of bleeding manifestations, no history suggestive of drug or CAM intake. There was no history suggestive of CTDs. The patient's past history was significant in the form of possible history of asthma. She had history of recurrent episodic shortness of breath requiring nebulizations, although the personal history was unremarkable. Her examination on presentation to EMOPD showed presence of hypotension, tachycardia, tachypnea, hypoxia, and pallor. Her systemic examination showed on auscultation V's was present. Her per-abdominal examination demonstrated ascites and presence of hepatomegaly. Coming on to the investigations, the patient had progressive drop in HB since her presentation to PGI. Her TLC remained high throughout the admission. With hypereosinophilia, we have 2 isolated reports. Platelet count at presentation was 31,000, and it has been persistent, although there is a rise in platelet pre-terminally. Coming to the biochemistry, patient had marked elevation of transaminases with AST more than ALT to the tune of around 10,000s. She also had AKI with a Bun-Creat ratio less than 20:1. We can also see there is deranged INR with a raised PT, APDT, and a reduced fibrinogen. Her ABG was suggestive of metabolic and respiratory acidosis. So a microbiological workup was done for this patient. The viral workup was negative. The tropical illness workup was suggestive of a borderline report for an IgM dengue test. The CART test with IgG dengue was found to be positive, which was done in the RICU. Other investigations were remarkable. The patient had a very high ferritin counts to the tune of 83,000, LDH levels of around 10,000, a high CK-NAC and hyperammonemia. Coming to the radiological investigations, the patient had the USG abdomen was showing an acalculous cholecystitis, bilateral pleural effusion, and an ascites suggesting polyserositis. The bedside DVD screen was negative, the 2D echo was also normal. So these are the radiology available with us. We can see the first X-ray on presentation to the EMOPD is grossly normal. The second X-ray on 11th shows a left upper zone homogeneous opacity with central trachea, which could suggest a query collapse or even a consolidation. There are some heterogeneous opacities on the right, middle, and lower zone with the perihilar haziness. The ECG showed sinus tachycardia. So coming to the course and management in this case, so this patient was managed outside with IV antibiotics and oxygen with the presentation as shown above. She worsened with worsening shortness of breath and metabolic acidosis, and then presented to PGI, where she was the antibiotics were started. She was IV NAC was also added in view of acute liver injury, and patient received nebulized bronchodilators and IV fluids. Inotropes were also started. Patient continued to worsen with worsening shortness of breath and metabolic acidosis. Component support was given, and patient by the evening of her first day of admission developed altered sensorium. For the same, she was intubated. On the same day in the evening, patient was shifted to RICU, where she was put on a ventilator on CMV mode, which showed high peak pressures and FiO2 requirement of 45%. By this time, the patient started to develop oral and nasal bleed, for which an ENT consult was done, followed by subsequent packing. Patient had developed oliguria and metabolic acidosis and underwent the first session of dialysis on the same day. Next day in the RICU, patient continued to worsen with worsening acidosis. By this time, patient had become anuric and underwent the second session of dialysis. She also developed an RT bleed, for which the GE consult was taken, and upper GI after stabilization was planned. She was also given more transfusions with FFPs and RDPs. The X-ray on the same day evening showed new opacities Patient had features suggestive of overt DIC with an ISTH score of 7. Finally, on the early morning of 12th, patient had a cardiac arrest and finally succumbed to her illness. Coming to the discussion in this case, I would discuss it along lines of various organ involvements and their differentials, possible basic etiology, and the pre-terminal events. So the database is of a young female with possible history of asthma who presented with the above mentioned complaints and on examination was hemodynamically unstable with V's on auscultation, hepatomegaly, and ascites. Her investigations had shown a thrombocytopenia, progressive drop in HB, coagulopathy, marked transaminitis, hyperammonemia, hyperbilirubinemia, a USG suggestive of acalculous cholecystitis, polyserositis, and a plus-minus evidence of serology and tropical illness. Coming to the multitude of tropical involvement, she had almost all organs involved. We come to the most striking organ involvement first in the form of liver. She fits into a classification of ALF syndromic diagnosis because she had marked transaminitis, coagulopathy, and altered sensorium with no apparent indication of a chronic liver disease. EASL classifies the causes of ALF as primary and secondary, with the classical causes being viral hepatitis and drug-induced in India, other causes being autoimmune and acute Wilson's. However, in this part of the world, we should also consider what are called as ALF mimickers, with sepsis, tropical infections, malignancies mimicking this presentation. So differentiating these, although the patient had a syndrome of ALF, but the serologies for viral markers were negative. Her ANA was negative, the ceruloplasmin was normal. Also the ALT by LDH ratio was less than 1.5, which goes against the diagnosis of viral etiology. ALT LDH ratio is suggestive of ischemic hepatitis, which is also a mimicker. Tropical illness with the patient's presentation of thrombocytopenia, polyserositis, and acalculous cholecystitis comes up high on the cards. Sepsis, though, can present with a similar picture, but would not explain the complete clinical presentation. Secondary HLH will definitely explain this presentation, but it has likely occurred on an underlying illness. Coming to the aspects of lung injury in this case, so the patient is likely to have an acute exacerbation of bronchial asthma. She was an asthmatic with the history of poorly controlled asthma with the high peak pressures once she was put on the ventilator. Also, she had V's on auscultation at presentation. A possibility of HAP has been kept because the patient had new onset opacities on the X-ray. However, this occurred pre-terminally. Since patient had ET bleed and a progressive drop in HB, a possibility of DAH has been kept. However, the radiology is not very characteristic. Same goes for ARDS. We have a P by F ratio which is reduced, suggesting ARDS, but the chest X-ray is not characteristically suggestive of the same. As the patient had overt DIC, a vascular pathology like PT cannot be ruled out in this case. Coming to acute kidney injury, we would first assume that the presence of fluid unresponsive shock, patient would have a prerenal etiology, but the Bund-Creat ratio goes against it. We do not have report of urine sediments available. Underlying septic acute tubular necrosis is one of the possibility. Patient had rapid onset oliguria with high CK-NAC levels, which suggests a possibility of rhabdomyolysis. In the presence of anemia, thrombocytopenia, renal injury, and encephalopathy, thrombotic microangiopathy does come to mind, although the PT and ABTT is prolonged in this case, and other than LDH, other hemolytic workup was negative. Patient also developed altered sensorium on the day of presentation. It can easily be explained by the syndrome of ALF with hyperammonemia, also aided by the presence of metabolic acidosis and shock. There was evidence of sepsis, so septic encephalopathy is a possibility. However, it is a diagnosis of exclusion. We do not have any CSF or neuroimaging available. It could be encephalitis secondary to an underlying tropical illness. However, again, the imaging and CSF is not available. Since patient had coagulopathy and thrombocytopenia, an intracranial bleed cannot be ruled out, although there were no focal neurological deficits and a neuroimaging is unavailable. Patient had hemat manifestations in the form of anemia, thrombocytopenia, and coagulopathy. Underlying tropical illness could explain thrombocytopenia, but unless complicated, would not explain coagulopathy and a progressive drop in HB. Secondary HLH and DIC would very well explain these complications on underlying primary illness. TTP-HUS have also been kept as a possibility, but the fact that prolonged PT and APDT go against them. So what is the basic etiology in this case? With the patient coming with AFI with thrombocytopenia with such a presentation, the spectrum of tropical illness must be considered. Coming to malaria, absence of splenomegaly and hemolytic workup being negative and negative serologies go against it. Dengue, on the other hand, checks all the boxes with most of the findings suggestive of dengue and plus minus evidence of serology. Lepto and scrub are not very far behind. They have characteristically they have characteristically more organ involvements. However, the serologies were negative and we could not find an evidence of a scar or conjunctival subfusions, although they might not be present in all the cases. The other possibility is also enteric fever. However, it is not the typical history for it. The other possibilities in the basic etiologies could be a hepatotropic viral infection. Even non-hepatotropic viruses, they would present like ALF, but again, biological evidence is not there. A flare of an underlying acute autoimmune disease has been kept because the patient was a young female with polyserositis. However, there was no history of CTD and ANA was negative. EGPA is a very remote possibility since patient had poorly controlled asthma with hypereosinophilia. However, this is not how EGPA presents. So coming to the pre-terminal events, patient had a likely hospital-acquired pneumonia with overt DIC, with a query of left upper lobe collapse and a refractory shock, which was septic plus hypovolemic. I would come to my final diagnosis in the form of severe dengue viral infection under expanded dengue syndrome, with dengue shock syndrome with oral GI and ET bleed, organ failures in the form of fulminant hyperacute liver failure, encephalopathy, AKI, and DIC, with pre-terminal events being a hospital-acquired pneumonia or query collapse, with the acute exacerbation of bronchial asthma, and a query of secondary HLH. Thank you.
Good morning, everyone. I will be presenting the autopsy findings of this case. This was a case of 25-year-old female with a short hospital stay of 2 days, with the clinical diagnosis of febrile illness, dengue IgM borderline positivity with acute kidney injury, acute liver failure, ventilator-associated pneumonia. Partial autopsy was done on this case. All the serous cavity were found within normal limits. The patient was heavy built and multiple ecchymotic patches were seen over arms, legs and feet. Serous cavity were found within normal limits. This is an organ complex comprising of liver, gallbladder, spleen, C-loop of duodenum and pancreas and spleen. Liver is slightly enlarged and overweight with the weight of 1640 grams. Capsular surface of the spleen is smooth. Gut surface of the spleen was found greasy to feel, and there is no focal lesion or nodularity present. Sections examined from the liver shows maintained lobular architecture with diffuse steatosis, and there is a focal portoportal bridging noted. On higher power, we can appreciate there is a diffuse panlobular macrovesicular steatosis, but there is no ballooning hepatocytes, there is no neutrophilic satelloidosis or any neutrophilic infiltrates. Portal tracts are regular without any inflammation or fibrosis. However, there were areas, focal areas of spotty necrosis were noted, but without any lobular inflammation. This is the reticulin stain, shows maintained reticulin framework. Even in the areas of spotty necrosis, there is no reticulin loss, indicating that necrosis is very acute, not a chronic. This is the Mason trichome stain highlighting the portal triad, shows maintained lobular architecture, and there is no significant fibrosis. However, it highlights the steatosis more evident. Summarizing the findings in the liver, in the view of elevated liver enzymes and spotty necrosis, ischemic hepatitis is suggested, and there is a diffuse macrovesicular steatosis. Section examined from spleen shows congested red pulp with the relative preservation of white pulps. Section examined from pancreas showed normal morphology. This is an organ complex comprising of tracheobronchial tree and bilateral lungs. The mucosa of the trachea shows congestion. Pleura of both the lungs show predominantly shiny with focal areas of hemorrhagic discoloration and consolidation. Both the lungs are firm to subcrepitant to feel. On cut surface, we can see there are multiple subpleural wedge-shaped hemorrhagic infarcts which are coalescing to form large confluent hemorrhagic areas covering almost entire lung, predominantly base of the lung. And there is no thrombi noted in any pulmonary veins. Sections taken from this hemorrhagic area shows diffuse alveolar hemorrhage and pulmonary edema. On high power, we can see these alveolar spaces are filled with RBCs. This is a section taken from segmental bronchus as it is surrounded by cartilage and submucosal glands. We can see the epithelium of the bronchus is ulcerated and the lumen contains mucosal plug and inflammatory infiltrates and some bluish area. On higher power, we can see this epithelium is ulcerated and it is replaced by fibrin and it is colored by the colonies of fungal profile. PA stain and Grocott stain were done for the better appreciation of the morphology of the fungus. Here we can see these fungal profiles are long, slender, septate with acute angle branching, which are consistent with the morphology of Aspergillus. These colonies of fungal profiles are not only restricted to the bronchus, but it is infiltrating the bronchial wall and infiltrating the surrounding smooth muscle, causing myolysis and infarction of the surrounding serous mucous glands and invading the lung parenchyma. This is another focus repeating the same. Here we can see the colonies of fungal profile invading the bronchial wall and invading the adjacent parenchyma. Here we can see a vein with fungal thrombi also. Even smaller bronchiole is clogged with fungal profiles and mixed neutrophilic rich infiltrates, which are eroding the epithelium of the bronchiole and invading the adjacent lung parenchyma. This picture depicting the pulmonary artery with fungal thrombi and inflammatory infiltrates causing vasculitis. Here a vein with fungal thrombi with inflammatory infiltrates causing vasculitis. This is a high power image to show vein with fungal thrombi. On further examination, we can see this formation of hyaline membrane along the alveolar wall, which is consistent with the diffuse alveolar damage. And surrounding alveolar space are filled with mixed inflammatory infiltrates. Summarizing the findings in the lung, there is an invasive aspergillosis, which is predominantly affecting the bronchus, probably ventilator associated, with angioinvasion, fungal thrombi, vasculitis, causing fungal bronchopneumonia. There is diffuse pulmonary hemorrhage with diffuse alveolar damage. Coming to the heart, both anterior and posterior surface were found grossly unremarkable with normal weight. There is no focal lesion or infarction noted. On cutting open, all the walls and all the chambers of the heart are relatively normal. There is no infarction, there is no hemorrhage or ring abscess noted. There is no thrombi present in any of the vessels. Sections were taken from all the walls and ventricles, in which two sections taken from the ventricle shows microscopic collection of nuclear debris and neutrophilic rich inflammatory infiltrates along with this fungal profile of Aspergillus. And it causes myolysis in the surrounding myocardium. This is a PA stain for the better appreciation of morphology of the fungus. Tissues taken from liver and heart were submitted for the PCR of dengue, lepto, scrub typhus were found to be negative. And in this picture, we can see these two are negative control, these two are positive control. Middle two are the test samples show negative result. Courtesy Department of Microbiology and Virology. This is an organ complex comprising of both kidneys, bilateral ureter and urinary bladder. Both the kidneys are found to be slightly swollen up and there is no focal lesion found grossly. On cut surface, we can see there is a distinct corticomedullary junction with medullary congestion. There is no focal lesion noted. Section examined from the kidney shows glomeruli with normal morphology without any proliferative lesion. Coming to tubular system, there is a simplification and shedding of epithelium noted in the tubules, which is consistent with acute tubular injury. On further examination, we can see a pigment cast, granular pigment cast inside the tubules, which is highlighted in the Mason's trichome stain. Here we can see the granular pigmented cast inside the tubules, possibly myoglobin. Interstitium and vascular compartment are relatively spared. This is an organ complex comprising of esophagus and stomach. There is a congestion noted in a mucosal aspect of the stomach. GE junction shows normal morphology microscopically. Grossly small intestine and large intestine are relatively normal. However, congestion is noted in the mucosal aspect of the small intestine. Microscopically, small intestine and large intestine show normal morphology with mild edema. Uterus is smooth and slightly enlarged in size. However, there is no focal lesion noted externally. On cut surface, there is no product of conception identified or any focal lesion noted. However, multiple hemorrhagic corpus luteal cysts ranging from 0.5 to 1.2 centimeter in the ovary. This section shows endometrium and myometrium. On higher power, we can notice a mild stromal edema in the endometrium, probably a secretory phase of endometrium.
Dr.
However,
Emmanuel,
there is no,
please hurry up.
However, there is no pregnancy-related changes identified. This is a section from ovary. We can see the hemorrhagic corpus luteal cyst with adjacent congested blood vessel. Sections from cervix and fallopian tube show normal morphology. Section from adrenal gland show normal morphology. Bone marrow shows normal morphology with adequate megakaryopoiesis. There is no significant hemophagocytosis. Section from muscle shows normal morphology. There is no myonecrosis or myocytolysis or any inflammation noted. Skin shows normal morphology. There is no vasculitis. Coming to final autopsy diagnosis, ventilator-associated angioinvasive aspergillosis involving both lungs with dissemination to heart, pulmonary thromboembolism, diffuse pulmonary hemorrhage with diffuse alveolar damage, diffuse steatosis with ischemic hepatitis, pigment-caused nephropathy, and acute tubular injury. Thank you.